They told you, with your personality, with your hair, with your hijab, with your skin color, with your preferences, with your gender. They told you, with their silence, with their words, with their resentment, with their absence. They told you, you don't belong. Yet, here you are.
So my name is S.Africa. I'm a final year medical student at the University of Manchester. I've been the ACID Medical Student Ambassador for the university, and I've been working with the EDI committee.
Hello, I'm Kate. I'm one of the fourth-year medical students at the University of Aberdeen, and I'm also the ambassador for ACID and EDI group.
I am Michael. I'm one of the surgical registrars in general surgery, and I'm the Equality and Diversity Officer for the Association of Surgeons in Training.
Here you are.
Professor Kokila Lakhoo is a consultant pediatric surgeon at the University of Oxford. She has honorary professorship at 3 African universities. She is the immediate past president of Global Initiative for Children's Surgery and the international desk for the British Association for Paediatric Surgeons.
Can you tell us about your daily routine?
Right, in person. So I get up at 5 in the morning, and then I do yoga exercises for half an hour. And it was something that was taught to me by my dad since I was 4 years of age. So I've continued that, not as vigorously like I used to do it, but I still do it daily. And then I go for a walk in the area, either in the park when it's light or on the road when it's dark, for about an hour. And then I get ready to come to work. So I start work around 7. Earlier than what most people in the department do, because what it does is it gives me a chance to just review some of my patients which are on the neonatal unit. So I come in through that door where the maternity is, see those, and then go down towards the children's hospital to attend the handover at 7:45. And then after that, routine days are ward rounds. And then after the ward rounds, it could be a clinic day or a theatre day, so it's work related. And then I finish off between 5 and 7 in the evenings, and then get home, and with my husband, we decide what we're going to cook. So we cook together and have a meal, and then I relax by maybe watching a bit of television, and then doze off on the sofa. And then get up, and we sometimes we have a cup of tea at about 9, 10 o'clock, and then I'm really tired and go to bed.
Where did you grow up? And the follow-up question, what was your fondest memory from childhood?
Okay. So I'm South African in 6 generations, and I grew up in a little hamlet called Bethel, which is not far from the Kruger National Park or the Swaziland borders. It's in the eastern part of the country. And it's a very small community, and we were very much, playing in the street, working together, doing things as a community. There was a huge community spirit in the sense that, you had parents, but everybody welcomed you. You were in people's houses. When you played as children, it was dinner time, you would eat at a friend's place where, you just send a message to your mom that, oh, the kids are all eating at one place. So very much a community-based upbringing, because we were a small community. And also I grew up during segregated times, so that made the people that were, there's a white community, and then there was the other community. And we were all very much together, because we didn't have all the facilities. They drew people together. And I really like that, and I've always instilled that in my own children as well, to say that living in the neighborhood with your neighbors, like in the UK, I live in a close, and we're a very young family. Everybody else was geriatric in the close, but we just became one big family, and because that's what I grew up with, and I think it is very refreshing and very healthy, mentally and socially, to have a community spirit.
So when and why did you decide to be a doctor?
So in our community, people were not wealthy, and my grandmother was a self-taught health visitor that used to help families with childbirth, with raising young children that have nutritional problems, working on burn, first aiding and things. And she worked very closely with a general practitioner who was a qualified doctor who understood what the problems were, but she served as the health visitor for him. And we live in a communal setup where, uncles and grandparents and us all children were in one household, so extended family system in the place. So I spent a lot of time with my grandmother and carrying her little medical bag to places where she went. And I think that's where my interest in working with people, helping people, understanding what poverty meant, because we were not very wealthy in the community, and working towards a common goal. I think those things came from that.
Were you always interested in pediatric surgery, and what led you to choose ped surgery as a specialty?
Okay, so I think once I took an interest in the healing profession. So when I got to school, and again in South Africa, because we were a segregated system, there were just basically, if you did well at school, there were basically three careers that you could take on where you would get a job, such as medicine, law, or accounting. Anything beyond that, like engineering or arts or sports, it was a closed shop. You couldn't get into those fields. So being one of the students that did well at school and interested in the healing profession, I took up medicine. When I did my medical school training, the Department of Obstetrics and Gynecology had a very vibrant, mixed kind of senior consultants. So in most of the other departments, we didn't see people of color in senior positions, whereas in Obs and Gynae, there were quite a few. And I think that stimulated me into that kind of profession. But when I started my junior doctor years, F1, F2 years, it was the surgery that attracted me. And during my F2 years, I rotated through the different surgical specialties. And in F1, we covered the pediatric surgical ward. And that's when I felt that, that I found my path. I really enjoyed children, and I really enjoyed the surgery in the children because I love theatre work.
And how was medical school life for you?
So, as I said, I grew up during segregated times. So when I went to a medical school that was for Black students only, and the medical school was put up for by the government. So there were about 6-7 medical schools in my country, and this was one for Black students only. And it was meant to just kind of qualify medical students to become general practitioners and look after their own communities. But we had, specialists that were trained abroad in Ireland and in the UK mainly, getting grants because we had the South African segregated system. So they came back with specialism, and there were tutors in medicine from that field, in Obs and Gynae. And so it was very vibrant in the sense that we lived through difficult times. We had a segregated system, but we were combined as, again, the community spirit of helping each other, working together. And I loved my medical school years because we knew that there were problems in the country. We used to run health clinics for the community where we lived, which was very deprived community. We did lots of health projects, doing like blood pressure checks and diabetic checks, and that in different communities which were around the medical school. Very kind of sports active, but we didn't have the facilities like our main campus, which was for white students only. They had all the sports facilities. We put up sticks and played football, and we had a swimming pool that was so crap, I can say. We had to clean it ourselves every now and again. We did a lot of sports that didn't require a lot of funding. In terms of training, I felt we got very good training because we had we were only focused on Black hospitals, and there were lots of patients and lots of need. So as medical students, we were trained to do. We just didn't have access to patients. We were trained to put in chest drains because there was such a big need. We were trained to have open and close abdomens. If we went to the obstetrics and gynae department, we were supported by midwives and our tutors to deliver babies. So we were clinically very astute in our training. And at that time, like, say you do an ESR, now you send, if you want an ESR, you send it to the lab. We used to put like blood in this columns, cylinders, and put it next to the patient and read it ourselves. All like, because in South Africa, the Durban area was very tropical. So we used to take stool samples and create slides and look for tropical diseases, like typhoid, and reading slides, amoeba, especially. We could read amoebiasis very easily. We used to do our own urine tests, like we used to concentrate in a centrifuge and then under the microscope look for these. We were taught how to look for these bugs. So our medical school training was so hands-on. We did lots of practical things, supervised. We had a microscope on the ward. We had patients that we could speak to, and our tutors were always around to help us through that. So yeah, a very enjoyable time. Yeah.
And what are the challenges that you encountered during your surgical training?
Yes, I think what I did is there were lots of barriers. So surgery generally it's a white male dominated world, but in South Africa even more so because of the segregated system. People of color, and especially women, whether they were of color or not, didn't get to enter the surgical field. You were always discouraged if you're a woman, and if you were a person of color, whether male or female, the doors were not open for you because it was very much a white male dominated supported system. So if you look at my training, just what I did is I really enjoyed surgery in my house job. And, I can just relate incidences, how things unfolded for me in that I was put into a unit where there was a very paranoid surgeon, and he was afraid of Black people. So he used to carry a gun at work thinking that they were going to harm him. And I was practically invisible because I was of color and I was a woman, and he just never saw me in the group. But one day, one of his thyroid patients that he did started bleeding. And, we always kept a suture pack next to any thyroid patient or any neck dissection so that if there was bleeding or obstruction, we could relieve the sutures and avoid a respiratory arrest. And I practically just undid the sutures, and saved the patient. And suddenly I became visible to him. And he was he saw me on the ward. He realized I was there all the time. And he was, saying that you will do fine wherever you go. So he gave me, he recognized, he just knew that I existed, which he didn't before. And then knowing that taking on a surgical career is going to be tough. So I did my primaries. So I took a year out to do what we call a table doc job. So it means anatomy tutor. So that the part one at that time was very difficult. You needed pure anatomy, pure physiology, pure pharmacology to actually pass the part one. So a lot of my contemporaries who were white who wanted to do that took on a table doc job. So I did similarly. And I was very lucky that the dental school which worked together with the medical school, really needed tutors that were interested in like head and neck stuff. And I kind of used a ploy to say, yes, I'm very interested in head and neck surgery. So I got the job. And then I came back with the, and then I wrote my part 1. So I had my part 1. I had, I started applying for the CT job. So in South Africa, it's like after your junior years and you get your part 1, then you get your CT job and go into registrarship, which is SPR here. So before you get to an SPR, you got to have your part 1. But as a CT, you were not actually required to have a part 1. But ours, the CT, was part 1 and interest in surgery. And the group of CTs that were employed, we had 10 of us in a group for surgery. And they decided, no, they want to cut it down to 8. And they just saw a woman with interest in surgery is not going to gel, so they fired me. And I didn't accept that fate. I went back to the hospital administration and said, look, I've got my part 1. I'm the only one interested in surgery compared to the other CTs. And I think with a lot of will and courage and determination, I didn't leave the office till I got my job back. So I was probably fired for about 6 hours. Got my job back. And again, that was because I was not the usual white male that they could identify with, like everyone sees that, oh, this would be the person successful. Anyway, I then got my job and I got my registrar post because I had the part 1. I followed all the rules and I had 3 papers to my name already, which I did with my, consultants when I did my F1 rotation. I did 1 paper in gynae and 1 paper in medicine, and one was a tropical one on typhoid. So 3 papers. So it put me into the right framework, and they felt, yes, they need registrars at the Black Hospital. So, okay, give it the job. I got put into a unit who was run, so there were 5 units. So this unit was run by Australian female surgeon called Professor Manel. And I was very, very pleased that I got put into that unit. A lot of people didn't want to go there, but I was very pleased because I felt it would be the good environment and a good person to learn from, because she was extremely skilled, very good, very thorough with her patients. And besides just the operating, but learning things around the patient would be good. I mean, she was very strict and people were afraid of joining that unit, but I really wanted to be there because I knew she would give me the best. And she also made the environment, like she didn't favor the females. I was the only female trainee registrar. She didn't favor me. I was one of the registrars, but I just felt that she understood where I was coming from in some ways. So the environment was very open and pleasant and learning in that way. And while I was there in South Africa, what they do is once you start your surgical training, a retired professor would act as your educational supervisor. And every 6 months, they would take reports from your clinical supervisor and see how you're progressing. So within the first 6 months, they will say to you, right, you're not cut out for surgery, you got to leave. So registrars were assessed. And then you have it every 6 months. So they give you about a year or 2 before they say you got to leave. Some people are given within the 6 months, they have to leave. And it's a really good system because you don't waste your time doing surgery if you're not cut out for it. So you got told under note that, look, if you're really desperate, we'll give you another 6 months, but you're just not going to make it in surgery because your mindset is different. I'm, talking about early days in the 80s, early 80s. So I would go there, and being the only person that was of color and a woman, and they never doubted my ability. They said, no, you're really good at your job. You're very conscientious. You know what you're doing. You're good with your patients, like trying to tell me that there's nothing wrong in your abilities. But they would say, you're a woman, why don't you go and do dermatology? Because you're going to start a family and it's not going to, it's going to be tough for you. You're not going to make it at the end, not because of your ability, but because of the society and social structure around you. Or, just give up medicine, marry a rich Indian man, and you know, you'll be set for life, you know. So that advice came every 6 months for about 2 years. But by then something happened, in the sense that I heard about if you have the South African Part 1, you could go to the UK and do the Part 2 without doing any clinical block or having to repeat the Part 1, because it was, the South African Part 1 was so well recognized. And Professor Manel also mentioned it to me. She says, look, get yourself recognized from an external university, and that might open more doors for you, you know. And so I knew about it from some of my white counterparts who were going to do it, you know, co-registrars who were going to go and do that exam. And so I thought about it, but when she said, look, you know, you should go for it, I did it. So I came to the UK and I did the 2 exams in Edinburgh and England, and passed them both. And when I got, and during that exam, it was the first time I ever touched a white patient. First time I ever examined a white patient. It was strange, you know, touching white skin. It was just very hard. But anyway, I got my exams, and when I came back, that's when the hospital, the university, my colleagues, the educational supervisors, the trainers acknowledged that I was going to be a surgical trainee, not going to give up. So that's the story. And ours was such that you did, your pediatric surgery came as a fellowship. So you had to do general surgery fully, qualified as a general surgeon and a consultant level, and then you did 2 years of fellowship in pediatric surgery.
And how was your first week as a consultant?
So the first day as a consultant, so I did my pediatric surgery, like as a pediatric surgeon, I was thoroughly trained again in South Africa in CapeTown at the Red Cross Children's Hospital to do pediatric surgery. And one of the things we had to do is have overseas experience to see how systems work abroad. And I think I did a year at Great Ormond straight through that system. And I was very pleased to have done that, because I didn't need to be taught pediatric surgery per se, as, you know, procedures and that, because I think South Africa trained me extremely well. But it's meeting people from other parts of the world. So I met lots of registrars or visitors or consultants from different parts of the world that passed through Great Ormond Street. I saw how a private system worked, because Great Ormond Street had a private system. I saw how much of wastage there was. I mean, the one thing that struck me was one night on call. It was about, I was doing the night call, and it was about 4 in the morning. We had just finished, and the senior nurse was cleaning the fridge out. And she just threw all these sandwiches away and drinks and put it in the bin because it was going to be refreshed in the morning. And I was just shocked that was happening. And also in theater, like a surgeon will open a suture and they say, oh, I didn't want this, and just throw it aside. Whereas in South Africa, you know, we take one string of a tie, and we'll use it till the end of the operation without opening another pack. So, you know, those were like the bad things I saw, but there are lots of good things about, you know, working as a team, working in a high-income setting where there are lots of prima donnas and everyone fighting their corner, which I wasn't used to, because we worked in a very community combined team working setup. So I learned about what is good and what to take back and what not to take back. And then when I got back to South Africa, I started my consultant job in the department that I had worked in at Baragwanath Hospital. I knew the consultants there. There were 2 senior officers, surgical officers. So they were like how you have your people that come through the CSO route, where they were trained abroad. They were, you know, hospital doctors. So they were called, the trust doctors they were called MOs. And in the Black Hospital, there were more MOs and very few training consultants. So it was really good team working, and they were desperate for pediatric surgery to develop. So it was really nice to be there.
Can I ask you about how did you overcome the challenges that you've encountered? You've mentioned some of them. Would you like to add on to anything?
Yeah. So I think knowing that, I was coming into an arena which was foreign to people, in that, I was a woman of color in a segregated country wanting to do surgery, which was mainly a white male dominated arena. Forget even black males hardly got into surgery. And I knew that this is what I wanted to do. And there were a lot of barriers, like, having to travel 70 kilometers a day to get to, tuition from the medical school area, where my white counterparts would just walk across from the white hospital to the medical school to get their postgraduate lectures, whereas I had to travel from one hospital to the other. Also the barriers of people saying, oh, she'll never make it, all of those. But I had the mindset that this is what I want to do. This is what I can do. This is what I love to do. This is what I'm able to do. Because in my work, nobody said, this is not how you do things. Nobody said that you can't do this. It was all about the fluff. It wasn't about my ability and my ability to learn surgery. It was about the fact that I was a black woman in a segregated country wanting to do surgery. You must be mad, But what I did is I had my mindset that I can do this. This is what I want to do. I'm breaking the barriers, right? Because if people see me, what I did is I looked at myself as a surgical trainee, like everybody else was training. These are the syllabus. This is what I want to do. And if people saw me differently, that was their problem. Yeah. It wasn't my problem. It was their problem. And I have the same attitude throughout the life, that even coming here in Oxford, if people do have those, unconscious biases, or people that are not used to seeing women of color in surgery, which was the fact in Oxford as well, then it was their problem, not mine. And so I didn't see it as my problem, so I survived it. It was a coping mechanism. Because if I did take all the nuances and the side remarks and the problems, ahead, then I would sink. And I wasn't going to sink because it wasn't my problem. I didn't see myself any different as an SPR or as a consultant surgeon or as an academic or as a trainer or whatever. I saw myself on par, on merit with my colleagues. I didn't want to be treated any differently, on par. And if people saw that as a problem, it's their problem.
These days, what motivates you to keep going in your professional career?
So I've balanced my life in the sense that, I'm married, I have 2 daughters, and kind of what inspires me is that I feel the thing I'm most proud of in all the bits that I've done in my career is that I was able to keep a full-time job, still remain happily married. I have 2 daughters who never saw a mother as an absent mother, and that I was able to enjoy and, a career in pediatric surgeon as a pediatric surgeon, also enjoy a career in academia, also enjoy working in global health, sharing my skills with people around the world and supporting whoever needed support, and collaborating with people on an equal footing to make things work. And it's about time management and working as a family unit. So my husband and myself never saw ourselves as this was the wife and this was the husband and this is how we're going to do it. We worked ourselves as a family unit and worked out our careers in such a way that a simple example is that in the morning I can control my time. So I would drop the children off at school, and in the afternoon I don't know because emergencies come in. So he would pick up the children. So he did a 7 to 3:30 job, and I did a job, which demands whatever you demands in pediatric surgery. And also I made a point of trying to work out that if I could live close to the hospital, have the school close to the hospital, and my husband's job, which he luckily got in a charity close to where we live, then we could walk to work. I always wanted to walk to work. So I could walk to work. So 2 hours of my time in the car is my time. I don't have to travel. The school was opposite where the hospital is. So I could take my children to school. And, schools have like little music day and little assemblies. And especially in junior school, they have little sports days. So I could just take the lunchtime off for half an hour, walk across, attend that music recital, and come back to work. So they never thought that mum was never there for us. And also in the evenings, like if I had, if there's an emergency, especially in the newborn, so you go and assess the baby and you say, right, this baby needs surgery. It's about 5, 6 o'clock. And then I could just walk home, have dinner with the family, read to the children, play with them, and they would go to bed. And by the time the patient gets ready for theatre, it might be 9 o'clock at night. And they wouldn't even know mum was gone and back. And even my husband sometimes didn't know that she had gone and back. So it kind of worked. I worked hard at making the atmosphere around me so that I don't compromise a family that I chose to have, and not compromise my career, which I chose to have. So I did everything in a way that wouldn't compromise people working around me. Like, in the family setting, live close by, make sure time management is good, make sure that the two of us work it together so the children are not compromised. In terms of colleagues, I took on a lot of global work, which I was invited to do and set up, but I made sure I did it with my own funds during my annual leave. So, because I had a full-time NHS job, so I don't compromise my colleagues because I'm there when I'm supposed to be there and even beyond. But if I did global work, which was on my own time, or research work that was on my own time, it was outside of the working time. So my colleagues didn't feel that, she was twiddling off to Africa on our time. So I did it in my annual leave and my own expenses, which made it so easy that I had no problem with colleagues.
What advice would you give to medical students and junior doctors in general, and those who are interested in global surgery?
Okay, so I think firstly, as medical students, if you want to come into medicine, you do it because firstly, you got to like it. You need to love to work with people. You need to be able to communicate, because a lot of your work is communicating with the team and communicating with the patient. And a lot of the times things go wrong because it's pure lack of communication. It's the communication that's so important. So loving the job, you've got to love people. You've got to be able to communicate, and you've got to be happy in what you do. If you find that coming to medical school, going through this lesson is a bind and it's really hurting you, then you shouldn't do it, And it's that the most important thing is you need to be honest with yourself, because it doesn't matter what I think or what your colleagues think or what your tutors think. If you are personally not happy with it, then be honest with yourself and say, look, this is not for me. And nobody will judge you for that. It's you that judge yourself. It's not a failure. It's a very brave person that comes into something and feels that this is not for them and moves on away from it, rather than using a financial reason or something else. Use it because just be true to yourself. If inside you don't feel this is for you, then don't do it. But if you feel that this is for you, no matter what the barriers are, you will swim. You'll swim. So I always say that be honest with yourself. Be sure that you enjoy this, because once you enjoy what you're doing, there are no barriers. They're just setbacks. There are no failures. Like, say, if you fail an exam, it's not a failure because you want to do that pediatric surgery. So it's a setback. It just meant that you were not right on that day, or you didn't get the right patient, or it just meant that you just needed a little bit more time. So there was a delay in what you had to do, So you need to have these mindsets. It's all in the mind. You need to be true to yourself. You need to, anything that makes you fall, you get up and start again. It's not a failure, it's a delay, you know. And then you need resilience, and that's how you build up resilience. And if you find somebody comes to you and says, you know, you're absolutely rubbish, why did you do this? And, you know, you get shouted at, or these days people don't shout, they just make you feel bad. And you think about it and why you're feeling bad about it. And that's where the resilience comes in. You'd feel that, okay, somebody's telling me off, go and find out why they said that, for what, and then you change it, you know. So the advice I give is that, you know, if you want to do something, you're determined to do it, you do it. And if people feel otherwise about it, then it's their problem, it's not your problem, you know. And also, like, don't use, if you're not good at something, or you didn't do something well, don't blame the system. Take responsibility to say, okay, that didn't go right, something I need to do to change it, right? Don't say, oh, you know, that consultant doesn't like me, or, you know, they were bullying me, they told me off, you know, I always get told off. Try and think about why this has happened. And you will feel much better, because you take it into your own hands. You deal with the problems that come about, because if you deal with it straight away and talk about it and go back to your nursing team or your consultant, there isn't a problem. It's pure communication or misunderstanding. You know, it's like if you get you know, a consultant say, oh, she's always late, or the team, your colleagues say, oh, you're always late. But, you know, they need to tell you that. And then it might be a pure reason you're late is because you're collecting results for patients before you're coming on the handover, and it delays you, you know. Always don't sit and sink in the problems that come about. Think about it and ask your colleagues, your teammates, why this is so, why do they think that way? And I feel very strongly that, you know, in this day and age, there's a lot of bad mindsets that when you are not doing well, then if you're told about it, then there's an accusation of bullying. And that's the minute you don't take responsibility for your action. It's like, as I said, you know, don't use your gender or your sexual preferences or your size or your diversity for your failings. Because if you do use all these as an excuses, you're going to fail. You will not make it, because you putting yourself forward as a victim all the time, rather than acknowledging is that there are gaps in your knowledge and you need to fill that. You know, so if you have that mindset, you can't fail.
Here you are.